I am Shannon Weber with Hive, a hub of positive sexual and reproductive health. It is May 2015. We're here in Washington, D.C. at the Elimination of Mother-to-Child Transmission Stakeholders Meeting. And I am with the amazing
Bill Short.
And tell me who you are,
Sure.
what you do, and how you got here.
Sure. How I got here today.
Yeah.
So my name is Bill Short. I'm an infectious disease physician. I work at Thomas Jefferson University in Philadelphia. I do general infectious disease, but really the bulk of my career and what I've done since I finished training was really take care of HIV positive individuals with a specific interest in women and specifically preventing mother-to-child transmission of HIV.
Awesome. And so really in the last 5-8 years, however long, there's been this idea that we should integrate preconception care into primary HIV care. And I think that there's a lot of real and perceived barriers for ID docs in doing that. And so and you've been a champion of this and really shared a lot of lessons learned with us about how we could do a better job of that. So I wanted to ask you about that. First of all, what changed for you? When did you go from the guy who didn't do it to the guy who does do it?
That's a great question. So I think really what happened when I first got out of fellowship, I finished ID training and I went to work in an HIV division, a whole HIV practice, and I was told I was the women's doc. So I said, what does that mean? They said, that's where your funding streams comes from. So I said, okay, I will be the women's doc then. So I quickly learned, and again, none of this was stuff I learned in training. I learned general infectious disease. I learned how to take care of HIV positive individuals. I learned how to prescribe antiretrovirals. I knew nothing about pregnancy. I knew nothing about women's health, contraception. So I just became the women doc. And as part of that, really what I was charged to do is really manage or co-manage the pregnancy clinic, the prenatal clinic. And so at that point, I really took on learning all there was to know about how to manage an HIV positive pregnant women. And so really my first year was really just focusing on once the pregnancy happened and how did I prevent mother-to-child transmission. And really what I gained over that first year was really a really deep insight into what was going on, or what was not going on, I should say. So I had a large percentage of women come in who were on efavirenz, and for those who are unaware, efavirenz at the time was a pregnancy category D, and really the concern was, was there going to be some damage to the neural tube? And it was really recommended not to use during pregnancy. Things have changed now, but at the time when I trained, this was really, so I kept wondering, why are all these women presenting on this medication when you're not supposed to be on it?
Right.
Women were coming in smoking, with mental illness, with uncontrolled hypertension, HIV not controlled, maybe hepatitis, that not controlled, not diagnosed. So I really start then taking a step back to, they should be entering this pregnancy a lot more healthier than they are. And at that point, I really start then focusing on, what can I do to get them healthy to maintain actually a more healthy and a healthier pregnancy and maybe a better outcome for the babies. So at that point, I started really getting into what was my job or my role as a clinician. And yes, I am an ID clinician, but really it was as an HIV clinician, what could I do to really help this along? And really that's when and I started learning more about preconception care.
Right.
Because again, I learned it during my OB rotation, but it was something I learned for that period of time and never really knew how to look at OB HIV positive patients in the context of preconception care, because there are some differences in it. So with that, I then started incorporating it into my just routine HIV clinic. Start looking at here are women who are not pregnant, what can I do to make them healthy when they get pregnant? And I think even take a step back is, I realized that during that year, I had never asked a woman once, had she wanted to get pregnant.
Right.
And she came to me and said, Dr. Short, I missed my period, and I did a pregnancy test. It was like, okay, you're pregnant. And I realized that I had not had a conversation with her the whole time. I was more focusing on the pregnancy and afterwards, but really not looking at the woman before the pregnancy, or the man for that matter.
Which I think is actually one of the lessons learned from perinatal HIV that we can apply elsewhere, is seeing people broader than that one visit that they're there for, or this one intervention that we're focused on.
Absolutely.
Seeing people as kind of whole people with reproductive desires or goals. So then when you realize you'd never asked a woman, do you want to get pregnant? How does your practice change, and how does that ripple in your clinic with other practitioners?
Sure. So I think what that really did to me was really set up sort of my mindset that I needed to start asking women, do you want to get pregnant? For a couple reasons. One, for their health, but I think also the notion in some of the HIV positive women's head was, I could not have a baby, and if I wanted to have a baby, I could only have it through a cesarean section. I would need to be cut, something I'm not interested in.
Right.
My partner's HIV negative, and there were so many questions that they had, and I realized until I asked, I didn't realize all the questions that were out there. And really, as a result, and which is how I came to meet you, I mean, all these questions, and I start getting involved more and being involved with our group, and really focusing on how can we incorporate this into practice. And I really have taken a particular interest in infectious disease doctors because, like myself, my goal was literally focusing on the sort of antiretrovirals in pregnancy and not really thinking before. And so what I did was really, when I went to, and I subsequently had transition clinics, really was just to sort of make sure everyone just asked basic questions. We'll focus on women, but I think we could talk about men, and I think
right.
That's a particular area that people need to focus on and don't think about. But really asking a woman is, do you have plans to become pregnant?
That also feels kind of overwhelming because, like you said, you didn't know how many questions there were out there until you started asking. And I think that's another real and/or perceived barrier that people have about starting down this road is like, okay, how much time? And you want me to now bring up vagina-related stuff? Like, that's not my scope, and I don't have time. So what's it like in real life, the amount of time that it takes up when you start asking women this question?
So in reality, I think if you're nervous about it, your perception is it's a lot longer than it really is.
Oh, good point.
It's real, because your anxiety level, I view it as sort of, why don't people test for HIV? I think there's a whole host of reasons, but one of the real big reasons that I've seen is people don't know what to do when they get a positive test result. What am I going to tell the patient? I've never told someone they had HIV. Mm-hmm. And I feel it's the same thing here. So you say to a woman, HIV positive woman in your clinic, you're on antiretrovirals, so do you want to have a baby now? No, I don't want to have a baby, and I don't want to have a baby in the next year or two. And then the question becomes, okay, I'm an ID physician. What do I do? And I'm going to face it, most providers don't want to say, I don't know what to do.
Right.
So I think at that point you really then, if you're uncomfortable with it, I think you just need to say that I am going to refer you to someone who does. I think the worst thing you could do, which is done, and we know this from data and from our own clinics, is that people just ignore the situation, and then you wind up having a patient who has HIV, and you've never asked a question, do they want to get pregnant?
Right. And so had you ever counseled someone about contraception before?
Yes.
And
so I counsel all the time.
Now you do it, but at the time,
all the time.
Was that part of your practice, or did you have to learn about that?
So I had to learn about it.
What was that learning curve like?
So I think it was very steep because, again, I had not done an OBGYN rotation since I was a third-year med student. And then once I got through my training and infectious disease fellowship, the sort of level of contraceptive knowledge went all the way down. But, it was just a matter of working in collaboration with people who knew how to do it. And then I learned from that, and I went out and read and learned what to do. And, at one point I was inserting IUDs and giving depot shots. And, now I sort of do a modified version. I don't no longer insert IUDs, but if I'm counseling a patient about things like IUDs, long-active reversible contraception, then I feel comfortable saying, you know what, this is something. First, I work with them to make sure they have an understanding of it. What are the benefits of that? Or let's just look at all the types of contraception, what you feel comfortable with. And then I refer. And I refer to people that I'm comfortable with, and they're willing to then take over and say, Dr. Short has counseled you about this, and then they go through their spiel. And
just like you would refer out for something else that
anything
you feel.
else. And I think it's something about reproduction that turns people off, because I think if the general ID provider said, Ms. Smith, you have diabetes, they would not hesitate to send that person to an endocrinologist and say, you need really good control of your diabetes. Well, this is the same thing. You want to prevent unintended pregnancies, and we know from the literature, very high percentage of HIV positive women, sometimes over 85%, actually have unintended pregnancies.
I think the president's flying in.
I think he is. He wants to hear this speech.
He wants to start doing preconception care too.
So, I think that you really have to, if you put this in your mindset that this is something that needs to be done, the way I think about it is, what is the general health of an HIV positive individual? Just so happens that the person in front of you is a woman. What are the things about an HIV positive woman that you would do? Take out the preconception piece. You would make sure she was healthy. You would make sure you counsel her about smoking. If she had diabetes, it would be under control. If she had hypertension, it would be under control. Hepatitis would be screened for it. Sexually transmitted infections. So what makes it different when she says she wants to get pregnant and you're doing the exact same things?
Good point.
There is no difference. And if you don't feel comfortable saying, all right, you don't want to get pregnant now, what can we do to do it? I'm going to refer you to someone. It's very simple.
And when we were talking earlier, you even mentioned it doesn't even have to be the doctor. It could be the nurse or the social worker. There can be different ways you integrate it into the clinic where at least the woman's asked.
Absolutely. It's just asking the simple question.
So tell me one story with an upside. I'm sure there's lots of challenges in this, but tell me a story in which this makes it worth it for you to have gone down this journey and done, which is frankly more work.
There's so many. I think, really, for me, it's really helping individuals. I go through a patient I have right now. It's so, not your traditional couple you think of. It's two females. But again, so I have a female patient in my clinic. If I did not ask her about her partner's another female, and she's HIV negative, and this patient's HIV positive. So I asked the question, and then so two females came in, and do you want to have a baby? And they do.
Beautiful.
And they actually work together to have a baby, and they're actually pregnant now. And
it's beautiful.
They're in our pregnancy clinic. We don't have a baby yet, but I mean, things like that are really, really positive, and they make you feel good about what you do.
Yeah. Well, thank you for leading the way in this and helping us to understand better. And
we got more to do.
We do, but we've gotten so far in part because of your work. So thank you.
Thank you. I think one last thing, or one point is, we talked a lot about women, but I think it's really important to include men in the conversation
Great.
as well.
Thank you for bringing that up.
And it's not only, it's not only men who have sex with women, but also men who have sex with men. I mean, however, you have to ask about their, do you want to have children now, in the future, at some point? And again, you have to ask the questions. And again, if you feel uncomfortable, there's always ways